Good evening, everybody, and welcome to the next Conversations with a Doc with Dr. Justin Martello. I'm going to tell you a little bit about him, and then I've got some actually really is exciting news that I just learned about 2 minutes ago. So Dr. Martello is a board-certified neurologist specializing in movement disorders and Parkinson's disease at Christiana Care Health System. He earned his medical degree from the University of Maryland in Baltimore, and he completed his neurology residency as well as his fellowship in movement disorders at the University of Maryland Medical Center. And after earning his bachelor's degree with honors in biology from the Catholic University of America in Washington, D.C., where he was a research team member at Johns Hopkins Kennedy Krieger Institute. So if those of you who came to our symposium last year, might have been in one of his breakout sessions, and Dr. Martello has certainly done Conversations with a Doc for us for a couple of times. When we were on before we started this, Dr. Martello was just telling us some very exciting news, and I'm going to let him explain to you what's going to be happening over there in Delaware. Dr. Martello, floor is yours.
Thank you, Judy. I was just mentioning that we recently purchased and installed a MRI-guided focused ultrasound procedure for treatment of essential tremors and Parkinson's disease tremors. And so many of you may be familiar with this because University of Maryland has had this machine for a number of years. I actually trained with it in my training, but we have it at Christiana, which is really nice because reimbursement wise, it works a lot better in other states, including Delaware, than it does Maryland based off of Medicare issues. And so, we're going to be able to scale up the procedure a lot more than Maryland, and they mostly have been using it for research purposes. So it's really exciting, and I'm sure Judy's going to want me to say that I'll be the only neurologist that's kind of running the program. As most all the other programs in the country are run by neurosurgeons and or with collaborations with neurologists. So it's kind of exciting times. But yeah, if you're interested in more, you're more than happy to, come and see us in clinic and discuss this as an option. But with no further ado, I'm going to go into the conversation or the talk tonight. So we are going to talk about management of non-motor symptoms. And as far as what we're going to cover today, I'm just going to go briefly over kind of the differences, especially when we're talking about Parkinson's, of motor symptoms versus non-motor symptoms, what is included in each of those kind of buckets. And then we're going to go into the different kind of main kind of sections of different, subtypes of what's included in non-motor symptoms, like involvement of the autonomic nervous system, psychiatric symptoms, sleep, a lot more that we'll discuss. And hopefully you'll be able to take away kind of real world ways to treat this and manage this more than just medications. It's not just about medications. So a lot of this is going to be, advice on, other conservative ways to treat this. This is being recorded, so if you miss anything, don't worry, you'll get the recording. And then, we will have time for questions in the end. So if you want to put them in the Q&A box, that probably would be the best way to do it, and then we'll address questions at the end. So many of you who have seen a lot of my talks know that I created this slide because I think it's a nice way to illustrate a lot of the more common symptoms with Parkinson's disease, and especially when we talk about the non-motor features. And so, when we talk about non-motor, we're talking about anything that really doesn't involve kind of physical symptoms, right? Things that you really can't see. Those typical physical motor symptoms are what we could call bradykinesia, or slowness of movements, rigidity or stiffness, tremors, right? Usually a resting tremor. But what else can be involved? So you have issues with cognitive impairment. You have issues with, memory, thinking. This also affects your dreams. People tend to have nightmares, vivid dreams, sleep issues, insomnia, REM sleep behavioral disorder, issues with lack of motivation or problems with motivation that can be very separate from issues like depression and anxiety. Patients can also have what's called psychosis, which would involve a number of things, hallucinations, visual hallucinations usually, illusions or kind of thinking that there's an actual object there, but you misperceive it as something else, or delusions. Those are kind of like ideas that are not based in reality. You can have vision changes in a number of ways, smell changes, changes in the volume and kind of hoarseness of your voice, slurred speech, drooling, nasal drip, swallowing problems, blood pressure issues, which tends to be one of the major things, constipation, and really just an overall slowing of your whole GI system. So gastroparesis is just another name for kind of slowing of your stomach. So you tend to be more easily full with meals. You tend to be bloated after meals. Fatigue, dystonia, erectile dysfunction issues, urinary incontinence, all GU issues. And so, and then finally, gait and balance probably more related to motor, excuse me, motor symptoms, but can be affected by a lot of these non-motor symptoms. And so this is not even all encompassing. It's just kind of the more kind of basic issues that more patients tend to share. Eventually with this disease, not everyone gets everything on this list. In fact, you may only get a third of the things on this list, but it tends to be, like I said, some of the more common issues, and we're going to discuss almost all of these tonight and ways to address them. Now, I highlight just real quick the loss or decreased sense of smell or anosmia, the constipation, and the REM sleep behavioral disorder, which is kind of like acting out your dreams at night, punching and kicking in your sleep, because these tends to be some of the early symptoms out of everything, even the motor symptoms that can occur years to decades before the classic motor symptoms start. So tends to be kind of a more or less a preview or risk factors of eventually developing Parkinson's. So this slide kind of shows you what progression looks like with different, with the non-motor symptoms inclusive, the motor symptoms, and then complications. And you can see that this at the x-axis is time in years, and we'll talk about why it starts at 0 here. And then the y-axis is degree of disability. And so time 0 is kind of when you develop the obvious symptoms and signs physically of Parkinson's, whether it's a resting tremor in one hand, or your decreased arm swing in one arm, or you're just weak or clumsy in a hand, things like that. But again, years, if not decades before, other things can start, and they usually do, like constipation, although somewhat nonspecific, the RBD or REM sleep behavioral issues, other sleep issues, depression, like I said, hyposmia or decreased or lack of a sense of smell. And so then you get to time 0, and the non-motor symptoms just continue to progress, and they may include pain, fatigue, MCI or mild cognitive impairment, kind of issues with memory, thinking, word finding, things that can happen with age too, of course. Urinary symptoms, blood pressure, dementia, and then, of course, your motor symptoms are worsening over time, and then you can have complications like fluctuations, dyskinesias, psychosis. So these things kind of build on each other, and so that's why, as you get, we usually think of the progression as a linear pattern, right? It continues at the same slope. But when a lot of these different issues start to compile on one another, and you start to get to, behind the 8 ball with treating them, you can have this kind of snowball effect where it just worsens, one worsens on top of the other, and it's just hard to keep up with. So the first kind of subset of non-motor symptoms we're going to talk about is the autonomic nervous system. And this picture, you're not supposed to be able to read it. It's just kind of a description of the different types of organs and body parts that your autonomic nervous system controls. And another way to think about this part of your nervous system is it controls everything you don't think about, from the way your pupils dilate or constrict, to the way your breathing is regulated, your heart rate, your blood pressure, your kidneys, your whole GI system, your liver, bladder, GU system, genitourinary system. All of that is essentially controlled by your autonomic nervous system. So what does this look like? Now, like I said, one of the main drivers and issues to especially the disability in Parkinson's is when you start having blood pressure issues. And so what does that look like? So there's something that's called neurogenic orthostatic hypotension. Now, what this means is that, so many of us can experience that if we bend down and get back up really quickly, we kind of feel dizzy or lightheaded. or stand up too quickly. We feel like we need to like correct ourselves before we get moving. Well, what happens is obviously gravity takes over when you stand up. The blood rushes to your feet or your legs and your veins, and there's other chemicals released, kind of constricts the veins and the blood vessels to pump that blood back up against gravity to get back to your heart and your brain. Well, in Parkinson's, eventually what happens is, and there are different theories of why this happens, but your body eventually doesn't respond that way. And so all of a sudden, the blood rushes to your feet and your brain loses the blood or doesn't see as much blood. And that's when you get the symptoms of lightheadedness and dizziness. Now, what this looks like besides those symptoms, some other people can get other types of symptoms like being really weak when they're walking around all of a sudden, or they can have a pain across their shoulder, or they can just start getting really spacey with their thinking. And so there's other symptoms besides the typical dizziness or lightheadedness. But what we try and look for in this is a drop of the blood pressure by at least 20 points for the systolic number, or 10 points for the diastolic. And then you don't see, so typically, let's just say you're really dehydrated. It's really hot outside, which actually a lot of patients get really symptomatic over the summer because of this. But let's just say you're really dehydrated, it's hot, and you get dizzy and lightheaded. That doesn't mean this is what's going on. And in fact, if you are dehydrated, what the body normally does, my body, any other body, since it sees this drop in blood pressure, the heart's like, well, we got to keep the flow somehow. And the blood pressure's not doing it. So we're going to increase the heart rate to keep that blood flowing to get to the brain. Okay. Because the blood pressure is not responding, the veins aren't responding yet. So we're going to raise the blood pressure, the heart rate. Well, in Parkinson's, you don't have that heart rate response. And that's what really makes these patients very symptomatic. And then they don't really get better unless they sit back down or lay down and the blood pressure is able to go back up. Now, so let's just say this starts happening. One of the, quote unquote, good things, if you can call it that, if this does start happening, is that most patients, this really means that most patients are eventually able to come off of all their blood pressure meds. Now, even if you're on, let's just say you had uncontrolled blood pressure for like 30 years, you're on like 4 different meds for your blood pressure. To be honest with you, I can almost guarantee you at some point in your disease, you're going to be able to come off those meds, right? Because this is going to start happening not only with progression of the disease, age also just in and of itself, and then also this next point, all of our dopamine medicines, whether or not you're talking about carbidopa, levodopa, or dopamine agonists, or whatever, almost all of them will drop your blood pressure. Okay, so they, not that we're using obviously Parkinson's medicines as blood pressure lowering medicines, but just know that this is going to be more of a reality for you. Now, I put this as an interesting kind of talking point. The goal blood pressure, anything under 180 over 120 is okay. Now, a lot of you are saying, well, that's crazy because my doctor said if I'm hanging out in the 140s, 150s, 160s, that's hypertension, that's high blood pressure. Well, if you do have this issue with Parkinson's, right? So I'm not talking about everyone right now, okay? But if you have this issue of NOH, this is your goal, because this is what happens when you develop this issue. Your blood pressure, if you hooked yourself up to a 24-hour blood pressure cuff, your blood pressure is going up and down all day long, not only because it changes in position and what you're doing, but even if you're sitting still, it's going up and down, okay? So the reality of the situation no longer is we're going to target 120 over 80. The whole understanding is there's going to be a range of blood pressures, and which one's better, higher ranges or lower ranges. And when you do the math as far as the risk benefits, high blood pressures, what do we worry about? Strokes, heart attacks, for the most part, right? Low blood pressures, and to say as far as strokes and heart attacks, we worry about that over a span of time. Like if you're 40 years old and you're hanging out in the blood pressure of 150s, I'm going to tell you, look, if you don't do something about that, sometime down the line, it may be 20, 30 years, but sometime you're going to have a heart attack and a stroke, right? So that's why we control the blood pressure. Well, to be honest with you, most patients, Parkinson's, are 60s, 70s, 80s who developed this issue. And so that hypothetical risk factor is not necessarily, as concerning as, again, if you're like 30s and 40s. Then what are the risks of too low blood pressure? Well, you have the dizziness, lightheadedness, you have decreased energy, fatigue issues, We're starting to learn more about cognitive issues with low blood pressure. Many patients with this issue feel like they think much more clearly and have much less confusion when they're hanging out in the 150s, 160s, sometimes even higher. They just feel better. Fall issues and risk of balance is much greater when your blood pressure drops. So you decrease the risk of fall. So all of these things, are on an at every minute basis, meaning, like I said, with the high blood pressures, those risks are over time. Well, if your blood pressure goes from, let's just say 160s to 100, with that 60-point drop, which many people do, that second you're gonna at a risk of falling or worse, confusion or getting injured, totally being out of it, making mistakes. So when we talk about like the ideal situation, there is no ideal. It's just which is less risky. And when we talk about it, it's really pushing you up higher. And by the way, it's really easy that let's just say, okay, we're allowing you to go higher. Let's say you went to the 180s, 190s. Guess what? You stand up, the blood pressure goes right back down. So it's much easier to treat higher blood pressure than it is low blood pressure. Now, we do have 3 treatments, medications to treat this issue. Midodrine, droxidopa, used to be called Northera, and then fludrocortisone or Florinef. And these are good medicines, or they can be. I will say that these are the only options. So when you're talking about only 3 options, and many times it is hard to control this issue, it still becomes a problem. Many patients can have side effects to it, mostly what's called supine hypertension. So when you do have this issue, one of the things that we tell you is to never lay flat. If you lay flat, especially on these medicines, your blood pressure definitely will spike. Now, having said that, if your blood pressure is dropping, right, and you get really dizzy and you're about to pass out, of course you want to lay flat. But as far as sleeping at night, sleeping during the day, you always want to keep your head of the bed elevated 30 degrees or 60 inches. 6 inches, not 60. Now, other things that you can do conservatively. So a lot of people talk about thigh-high tights, okay? That's actually not what the study showed was actually effective. You actually have to do tights, and I know it sucks, especially women and men, to do this, and especially in the summer, right? But you actually have to wear tights that go all the way up to your waist for it to be really effective. Now, there is some data for abdominal binders being helpful. And yes, if you had tights that go up to your thighs, maybe that's going to be somewhat helpful, and obviously it's going to be very hard to get in and out of. I do know they sell, I think on Amazon, tights that actually zip up the sides. So a little bit easier to get on and off. But that's one way. Obviously, the big thing that we mentioned is hydration. So you do really need to drink close to 64 ounces of water. Now we talked about, smart water, flavored water, low calorie Gatorades or Powerades are definitely good. And a lot of times you need those electrolytes and salt in the drinks to keep the fluids more in you. So sometimes it's even better to stick to the Gatorades or smart waters of the world for that reason. Again, 64 ounces. And if you don't have a water bottle in front of you at all times, you're going to forget. And so I usually recommend, having your care partners, help you to remind you to do this. Try and keep up with the hydration, super important. A lot of people will avoid the hydration because they have to pee more. And again, going back to the salt intake is important, electrolytes in your drinks. And then ultimately we'll talk about this later, but working with your urologist on treating the urinary frequency issues. We talked about the head of the bed, 30 degrees or 6 inches at all times. And this also helps even if you're not on the meds for keeping your blood pressure regulated better. And then salt. And actually, it's interesting. This is, again, whether or not you want to consider this a good part of Parkinson's. You actually, if you have this issue, not only do we want you to do the opposite of everyone else with salt, but like super opposite. We're talking like sometimes like 3 to 5 times the amount of salt we recommend for a normal person. So we're talking about like going to McDonald's and having fries 3 times a day type of salt, right? Like super, super salt. And so that's actually even why they sell over-the-counter salt tabs for people who don't want to really do that much salt in their diet or don't like the taste. Then a lot of times we'll recommend salt tabs. Either they usually come in 1 gram or 2 gram tablets, either doing 1 or 2 of them a day. Again, the normal recommendation for someone is 2 grams a day of salt. Again, for people who deal with this, you're talking about 6 to 10 grams at least, sometimes even more. So we're talking about, yeah, lots of salt. All right, other ways. Obviously getting up slowly in the morning is going to be helpful. So ice water. So if you ever, again, if you feel lightheaded or dizzy, the blood pressure is dropping, besides sitting down, laying down, having really, really ice cold glass of water can really help to increase the blood pressure. The way that works is you drink really ice cold glass of water, it gets to your stomach, it actually makes the blood vessels constrict in your GI system, pushes the blood out from the GI and back up to things like your heart and your brain. Avoid constipation, when you're straining, and we'll talk about constipation in a second, but again, everyone has experienced this where you strain too hard and you get kind of a little bit lightheaded. That's the vagal response. And so that will actually tank your blood pressure too. Many people talk about this after having a bowel movement. People really get dizzy, lightheaded, and weak. And that's because the blood pressure is dropping, especially if you're straining. Avoid really hot showers and baths. Again, that's going to expand the blood vessels in your extremities, right? It's trying to release heat, and that takes away from the blood going to your heart and your brain. Avoid large meals, again, for the reasons I mentioned about blood flow, right? You eat a large meal and your blood flow wants to be directed to your GI system, taking away blood flow from everywhere else. And so eating smaller, more frequent meals, and again, this can help with, we'll talk about this later, with issues with gastroparesis and constipation too. And then everyone's always worse in the summer. It's just like clockwork. So just be really careful to extra hydrate in the summer, especially if you're going outside. All right, so constipation, or in general, a slow GI system. So these are some foods that are good for constipation. Obviously, just anything high in fiber. The goal is really, one bowel movement a day. And yeah, we're not going to go crazy if you're every other day kind of having a bowel movement, but the goal would be at once every day. So hydration, exercise, fiber, prunes, all good things to start with for sure. But many times this doesn't do it enough. And so we talked about over-the-counters that are pretty safe, usually stool softeners like Docusate or Colace, and then Senna as well, up to 2 tabs for both of them twice a day. So again, you can start with either one, slowly increase it over time. Every few days, go up and up and up, all the way to 2 twice a day. If you have to add in the other one too on top of it, so that you're on both 2 tabs twice a day, that's what you got to do. Miralax, milk magnesia, enemas, suppositories are all good to be used as needed. It's rare, but some people do need to use some of these things every day. If you do, especially with Miralax, you need to be careful with your hydration because it uses the water in your body to make things flow. And so you just got to keep up with the hydration. And this is one of the reasons why we don't like Metamucil as much. It's not the end of the world. If you do great with Metamucil, just continue with it. But many times, again, if you're not keeping up with the hydration, this can actually cause more binding issues and be problematic with that. And then there are prescription medications. There's a bunch of them. Excuse me, Linzess, Amitiza are a couple, Trulance. There's a bunch, the Motegrity. There's a bunch out there. A lot of them are obviously, advertised for other reasons for constipation, but at least Linzess and Amitiza does have some data for Parkinson's, but many people do need prescription medicines for constipation too. So the GU system, pretty much anything involved with your urinary system can be affected. Everything from, most of the time, it's frequency, especially overnight, during the day, leakage, incontinence. Sometimes it could be retention too. Sometimes these can be from medications as well, of course. So obviously asking your doctor about that. And the one thing, and then erectile dysfunction, decreased libido could be with this too. This is the one kind of organ system of the body and of the autonomic nervous system that we really tell you to see a urologist or urogynecologist first, before we just assume it's Parkinson's. Now, I tell you, most of the time it will be from Parkinson's, but as an aging adult, man or woman, you have so many other reasons, especially correctable, reversible reasons to have this as an issue, and you would hate to miss out on that if it is correctable, right? If it's from Parkinson's, it's not like it's the end of the world and there's something to do about it. There are things to do about it, but you much rather find something else and just assume it's Parkinson's. And then if it is Parkinson's, to be honest, anything that the urologist is going to recommend is something that we're going to recommend too. There's meds, there's bladder stimulators, there's Botox, there's a lot of different things depending on what your issue is, and the urologists are more equipped to treating it. Having said that, if they're like, there's nothing to do for you, it's just, it's part from Parkinson's, or there's only meds for, I can't offer you anything else, then a lot of times your movement disorder specialist can manage those medicines as well. And there are some medicines that we have to be careful about, especially oxybutynin, which can be used well at night, but during the day can cause some cognitive issues and other issues. So, for the most part, urologists are pretty equipped to dealing with this. So other autonomic changes, so drooling issues. This is more of a problem with, normally most of us clear our saliva on our own. We don't even think about it. And Parkinson's patients say their muscles are just not moving that well anymore to do that in their mouth. And so it just tends to pool in their mouth. It's not like it's an excessive amount of saliva production. It just tends to pool and then come out. And chewing gum can be a way to help with it. Obviously no one likes to just chew gum all the time, so it's not necessarily practical long term, but as needed, it can be helpful. Atropine drops. So atropine they sell as an eye dropper for different types of eye conditions like glaucoma. But what we have found out and what we know is that if you use the drops underneath your tongue, so if you get this, it's a prescription. So if you get the prescription from and many of us neurologists will prescribe it, it will actually say it's an eye dropper, but you're actually going to use it underneath the tongue, and that helps to cut down on the drooling production. And you can just use it as needed. So it's not like you have to use it every day. You can, but that tends to be a nice way, because I will tell you, the last point on the list says avoid glycopyrrolate. There are oral medications like glycopyrrolate for drooling. The problem is that they have a lot of cognitive issues, a lot of confusion and memory issues and things like that. And so we really don't like to use that in Parkinson's. But with atropine, it only works at a local level, just right here in your mouth. And so it doesn't have, systemic side effects. And then if the drops don't work, then we use botulinum toxin injections or Botox to treat it. You do have, as this picture shows, a couple saliva glands that we target on either side of your face. It's a very small needle, very quick injection. It's not worth really talking about in the sense that it's really easy to do. There's not really any side effect except if you over dry the mouth. But I'll tell you, it's really, even that's pretty rare to do. And we start out with a low dose, see how it goes, and then we can increase the dose. You only need it once every 3 months, and it's very easy to do, especially if you're already seeing your doctor for Parkinson's. So dysphagia, so swallowing difficulties. Again, not everyone gets this, but and if it does happen, it's usually later in the disease. Most of the time when we see this, it starts with liquids first. And so a lot of people come to me and they say, well, I have a lot of problems with swallowing pills, or I have a lot of problems with swallowing different types of food, and I have to cut up my food really small. Well, if that's the first kind of sign, a lot of times we'll tell you to go see ENT first, so they can do a video scope down your esophagus and see if there's any structural changes. Many people develop these structural changes in their esophagus just randomly with age. And most of the time they are correctable with different procedures that the ear, nose, and throat doctor can do. So if it starts that way, it's not Parkinson's, just aging. Having said that, if you do come and say, yeah, it's, whenever I'm drinking water, I tend to cough after drinking and swallowing, that's a warning sign that that's some swallowing problems due to Parkinson's. And then usually we'll send you to a speech and language pathologist to work up your swallowing. Many times they will want us to order what's called a modified barium swallow or a video swallow study. It's kind of just an imaging of you drink a dye, and they take pictures as the dye goes down your throat to see if it's going into your lungs a little bit too. And if that happens, well, then unfortunately, you may have to start to thicken your liquids. There's something called Thicket that they sell just in pharmacies and in Walmarts and other places that thickens thin liquids like water. A lot of people don't like the taste of this. There is something called Simply Thick that you can also buy on Amazon or in local stores that tastes a little bit better, but it's much more expensive. So, that's the issue. I will tell you that when it comes to swallowing problems, uh, it's quality of life comes into play. For example, and there's really no right answer here. What I usually tell patients is, okay, you clearly have swallowing issues that in order to be safe and not aspirate and have things go into your lungs, which can cause infections and cut down on your life, you really should thicken your liquids. Well, the patient comes back and says, look, I tried to thicken it tastes awful and I don't want to live like that. I just want to drink whatever I want to drink. Just let me drink it and I'm fine. I don't care if my life will be shortened a little bit because I might get an infection a little bit earlier and go downhill, but it's not worth it. I want to just drink and eat whatever I want to drink and eat. And so to be honest, it's not wrong, right? It's like quality of life over quantity of life. It's whatever you want to do. And so we just give you all the information and you make your decision, right? Temperature changes. So your body temperature regulation is under the autonomic nervous system. A lot of people have this. A lot of people get really sensitive to heat or cold. Um, if you're always like that, that's not necessarily the case, but a lot of people will change with Parkinson's. The way you sweat, the amount you're sweating and what locations you're sweating at changes. And really, for this whole bucket of issues, it's really just environmental changes, meaning, if you're cold all the time, wear more clothes, right? And it's hard because obviously you live with other people who don't have that kind of temperature issue. So I'm not saying it's easy, but there's no like special medicine or over the counter or anything like that, unfortunately, to address that part. So moving on to psychiatric issues. So mostly we talk about depression, anxiety as being the two biggest buckets, usually can affect about 50% of people with Parkinson's. And, and this does not, I have this picture up here about the dopamine pathways, serotonin pathways. Both of these are neurotransmitters that are natural chemicals in your brain. In people with Parkinson's, these chemicals are way usually downregulated. And it's not as easy always as about taking a pill, but I will say that because they are chemical changes in your brain, these symptoms of depression and anxiety is not like, oh, I'm depressed because I have Parkinson's, or I'm depressed because I just lost my partner, or whatever. Obviously, those are periods of sadness and times to be sad, but we're talking about like nothing is going on and you're just feeling very low, very depressed. You're not even thinking about anything, or maybe you are thinking about something, but it's not a big deal, and you're getting super depressed or super anxious all the time, just constantly nervous, worried about things, right? Again, it has nothing to do with necessarily what's going on around you. It's from the disease. And so, I say it's not about taking meds all the time, and it's not. But unfortunately, because we're talking about a chemical imbalance, many times you really do need some of these medications to kind of re-regulate things. And it's not as easy as taking the Parkinson's meds, even though they do work on the dopamine system, because they're mostly working on your motor symptoms, not your non-motor symptoms. Apathy, I mentioned before, a lack of motivation. Many times, you talk to someone, or your loved one is like, I just don't want to leave the house. Um, I don't want to do anything. And you're like, wow, you must be really depressed. But a lot of these people will say, hey, you know what? I'm not depressed. I'm not happy either. I'm just kind of here. I don't really care. Right. So apathy can go with depression, but it can be very separate. And then psychosis we talked about, and then impulsivity we'll touch on. So we talked about this, people who are depressed, anxious, and these are kind of feelings that they may describe. We talked about apathy versus depression. Many times we do recommend, talk therapy, seeing a psychologist, seeing a therapist. We actually have a neuropsychologist, a part of our clinic, who deals with a lot of patients with this. And sometimes a lot of patients just need help with coping with a chronic disease, which is what our neuropsychologist does. She'll actually see you for usually about 12 sessions. And that's usually all patients need to really learn ways to, again, better cope with dealing with the disease. But again, not many times this doesn't go far enough, and so there are medication options. pretty much almost any medication that we have in existence for depression and anxiety are okay to use in Parkinson's. Yes, there are some that are more studied than others, and so those are the ones we tend to use. And it just depends on your symptoms too. But you know, many people need these additional medicines, and it can really make a big quality of life change for them. And then a lot of things that can be helpful, especially for apathy too. It's just being engaged, getting out there, having planned activities, socially, keeping your brain active mentally, and physically. I will say, obviously these issues exponentially went up during the pandemic. That's why, to be honest, as kind of a example, and I know you have good examples with maps. To do this as well. I mean, besides, of course, they offer virtual talks and things like that. But, for our symposium last year and this year, we're only doing in person only, right? And the point of that is not to limit the education for others, but it's really to tell you that nothing can replace social interactions, getting out there, being engaged with other people, especially now in 2024. And so you really need to be deliberate, or at least have others help you with that. So, um, psychosis, I know it's not a good term that we use for this. It's kind of a bucket term, but that includes visual hallucinations, usually early on with most of these things, even not in this category, but even with the other symptoms. Most of these symptoms start out very mild, right? And it's just very gradual. Same thing with this. Not like one day you wake up and you start seeing people or animals all over the place. It's really like benign things that, to be honest, like some people may have normally, like, a shadow that you think you saw in the corner of your vision, you look, there's nothing there. Or you walk into a dark room and there's a lampshade, and you're like, is that someone standing there? And you turn on the light, oh, just a lampshade, right? So it does usually be as easy as that. Now, I will say that for most of us, yeah, we can get that from time to time and we just kind of brush it off, right? If you ask people with Parkinson's, they know it's different. They they have a sense, like, not only is that not like a typical human experience type thing, but like something's happening, right? A lot of them will get this sensation that someone's standing behind them, there's no one there. So this is kind of now a lot of people say, well, I have visual hallucinations all the time, but it's like I wake up in the morning and I still see people. When it stems out of sleep or around sleep, like you're drifting into sleep or drifting out of sleep, even during the day, I'm not saying you shouldn't tell your doctor, but it's not as concerning of an issue as like this is happening in the middle of the day and you're wide awake type of thing. And then also we talk about delusions. So these are, again, thoughts or ideas not based in reality. So, my spouse is someone else, or I don't recognize him or her. I still think that dead people who are old family members are still alive. I still, I'm disoriented. I think and then I start, maybe I'm a little paranoid. I start thinking the mailman's stealing from me, or unfortunately, one of the more common ones is called delusional jealousy. And so it it sucks. I mean, this what it means is that you think that your spouse is cheating on you, and this could be like you're 90 years old and you've been married for 60 years, and you think all of a sudden she's doing that, right? So it you know, these are all obviously problematic issues. There's a lot of reasons for this to come up, not just because of the disease. It can be from, to be honest, our Parkinson's medicines will increase the risk of this. It can be from other medications. It can be from illnesses. So if you ever have had someone who's gone, even having a simple cold or urinary tract infection or the flu or whatever, infections can make you at more risk of having this. Usually that's temporary while you're dealing with the infection. If you're not getting good sleep, if you have other uncontrolled depression issues, you're at more risk of this. So there's a lot of overlapping buckets that can really push someone into having this. And it doesn't mean they're going to be long term, right? Again, if you told me, oh God, doctor, I had all these hallucinations while I was in the hospital because I was having a heart attack or whatever. No, that's just the hospitalization. That's just the stressor that your body was under. That has no bearing on what you're going to develop later. So, um, it all depends on context too. So as far as treatments go, we used to take the approach where, if we would ask, does it bother you? Right. And we would a lot of times get a response, no, I don't care. In fact, a lot of, older people will say, no, it's nice. I see little kids running around, or I see, my old dog that died and I love it and it's great, fine. We say, okay, we're not going to treat it. Well, the problem is that, well, we are starting to find out that if you kind of quote unquote let it go, what can happen is it can worsen over time, it becoming more frequent, more severe, and then it actually can start impacting your cognition too, your cognitive abilities. And this makes sense on a common sense level because let's just say, imagine if you are seeing things, right, that are not there, or thinking different thoughts that just can't escape your brain. That's really distracting you from being in the moment with someone and really listening and comprehending and putting to memory what they're saying. And so you're really just not focused and concentrating or just not there. So it is something that if it is somewhat common, meaning some people will say, yeah, I have like an hallucination maybe like once a month or something like that. No, we don't need to treat that, right? But if you're having it more regularly, every day or every few days or, more than that, then it is a good idea to consider treatment. And it may not be, an extra pill. It just may be, excuse me, may mean that you just need to talk to your neurologist about adjusting some of your other medicines or looking at your medicines in general and saying, are any of these like, is any of this making this worse, right? Or what can I do about it? So as far as medications go, there is a class of medicines called neuroleptics or antipsychotics. Um, all of these are off limits. Now, there are some exceptions, and we'll talk about them. But if you look them up and they're under this class, it's usually not safe for Parkinson's because they're all involving dopamine blocking. And what are we doing in Parkinson's treatments? We're giving dopamine, right? So we don't want to block what we're giving, right? Now, exceptions to this. There's a medicine called quetiapine or Seroquel. Very helpful for this issue. It can actually help kill two birds with one stone insofar as it can help with insomnia issues with Parkinson's. And so, a lot of times I will start with this. It's cheap. It comes in a generic, easy to use. It's quick acting. So all those are helpful. There's a brand name medicine called Nuplazid, otherwise known as pimavanserin. It's a generic. It doesn't come in generic yet. It usually needs at least several weeks to kick in. It can be expensive because it's a brand name medicine, but it technically is the only FDA indicated medicine for Parkinson's disease psychosis. So it is very safe. It is very effective in Parkinson's. It's nice because it only comes in one type of dose. So it's either going to work or it's not, right? There's no titration. There's no weaning off. It literally just one size pill, 34 milligrams. That's it. One time a day. So it's very easy to use. And then there's a medicine called clozapine or clozaril. This is something where it is very effective, but there's a big but. It does have a rare, and it's, to be honest, it's super rare, but the FDA doesn't like, I mean, we all don't like that if you do have it, it's a problem. It can lower your blood counts as a very rare side effect. So you have to have frequent blood monitoring for this, meaning every week for the first 6 months, and then every 2 weeks for the 6 months, and then monthly after that. I do have patients on this right now that I monitor with it because it does work very well and it can be very well tolerated. It's just the blood monitoring that is just a lot. All right, impulsivity. So impulse control disorders, it's something that can happen a lot of times from Parkinson's medications, especially dopamine agonists, uncontrolled gambling, shopping, internet surfing, binge eating, sexual interests and actions. And this can get out of hand. And now you do know this is happening and loved ones know it's happening. So it's usually something that, as long as we adjust your dopamine agonist and lower it down, we can treat it or switch you off. This will go away. But really, other dopaminergic meds can cause this as well. And then a lot of times, absent of the medications, although again, the medications can worsen it, people can get pretty impulsive with their actions. And this goes hand in hand with dementia issues as well. And so, this is a great picture because again, like how many times have I heard like, well, I fell because I was bending over because I was trying to, I actually, what did I hear today? I was bending over. Oh, because this woman was trying to pick up ice cubes from the ground. Well, you know how hard it is to pick up ice cubes, even for someone like myself. And you can only imagine. And she needed a cane at all times. So she's like with her cane, reaching down, trying to pick up ice cubes. So again, but whether it's, the lack of just remembering what you can and can't do safely to just, again, being impulsive, like your brain is moving faster than your body and you just don't think about doing some of these things safely. And really just having, someone with you, trying to treat the dementia part of things can somewhat help with this. And again, adjusting the dopamine medicines can be helpful. All right, almost through. So mild cognitive impairment. So mild cognitive impairment is described as a general decline, usually in at least two cognitive domains. Most of the people have issues with short-term memory and word finding issues, but it can be executive functioning. This really is like multitasking, planning, organizing, following directions, steps, things like that. Language, memory, visual spatial issues. So understanding where things are in space, where you are in space. And then there's usually an impairment in some kind of independent activity of daily living. That includes driving, doing your finances, preparing meals, like I said, planning events. About a third of people will get this, as far as at any one point, but in your whole lifespan, there is a pretty good chance you'll get at least very mild effects from this. And again, age also compounds on this. When we talk about dementia, a lot of people kind of conflate it with Lewy body dementia. So I wanted to kind of say a word about that. Um, Lewy bodies are actually just accumulations of alpha-synuclein, which is an abnormal protein that develops in these bodies. And then these bodies kind of get involved in different types of neuron cells and actually other cells in your body too. And it leads to kind of cell death, especially in the substantia nigra, which makes the dopamine. So it's kind of a misnomer when we talk about Lewy bodies because they're both in Parkinson's and Lewy body dementia, but there is a difference. There's a difference in where we find the Lewy bodies and the different diseases. Lewy body dementia is far more faster progressive than Parkinson's and involves early gait imbalance issues, early issues with autonomic dysfunction, which we've talked about, early dementia, and then fluctuations in attention arousal. These patients will go from like awake to sleeping to awake all day long. Their Parkinsonism, their motor symptoms are usually on both sides of their body. But the main difference that we look for, because a lot of these things, sometimes you're like, okay, well, I have Parkinson's and I have all those things, right? And maybe my Parkinson's is a little bit faster progressing than others. So do I really have Parkinson's or do I have Lewy body dementia? The one defining factor between the two that still exists in our ways that we clinically diagnose this is then you need the psychosis. So again, the hallucinations, delusions within the first year of motor symptoms. So again, you can have two people and they both look the same. One has Lewy body, the other has Parkinson's, but the difference is the Lewy body said, "Oh yeah, I mean, I developed a resting tremor like 2 years ago, and then like 6 months later, I wound up seeing things." Versus the Parkinson's person will say, "Well, I've had Parkinson's for like 15 years, and all this stuff just started happening now, right?" So, all right, so managing dementia. A lot of times we'll talk about treating depression, anxiety, and then also insomnia, as ways to help this because we know that even with, heck, even teenagers have been studied, and if they have any of these issues that are uncontrolled, they're doing worse on their tests, right? It's just a known fact. So this is some of the best ways that we treat this is we get you sleeping better, we make sure you don't have uncontrolled depression, anxiety, and then your thinking is much more clearer. Same along the lines of the blood pressure, as I mentioned before. There are dementia medicines. These are all initially approved for Alzheimer's dementia, but have been studied later and also approved to be treated in Parkinson's. And this is usually the order we use them: rivastigmine, then donepezil, then memantine, based off their level of evidence for Parkinson's. Stimulants have been not really found to be helpful, although some people are on them, like Ritalin or modafinil or armodafinil. Obviously we go over fall and safety issues, PT, physical therapy. Obviously, we're looking for swallowing problems at this point, weight loss. exercise is the only thing that will slow down the progression of both Parkinson's disease and dementia. So it's still the most important thing, even over mental games. There's a plethora of data showing that physical exercise outweighs even mental exercise, although that's important, right? We want you to keep your brain active too. But if there was ever a choice between one or the other, it's always physical exercise that trumps it. And then caregiver support, obviously, when it comes to this symptom and people with Parkinson's, it definitely affects much more, the caregiver, because the patient obviously a lot of times doesn't have the insight and judgment to deal with this. I show this picture of driving because, to be honest, if there is an issue with driving, it usually starts because of this. It's usually not because of the motor symptoms. A lot of people will say, "Oh, you're slower to respond, you're slower reaction times," and that's all true. But to be honest, it's really the idea that you can no longer multitask and plan and organize, which we all do. We don't even think about it on the road. And that starts to become affecting your executive functioning. You know, you have to know where you're going. You have to follow the rules of the road. You have to follow the signs. You have to know where everyone else is in space, other people and cars and dogs and all this kind of stuff, that it just gets to be overwhelming. And so it's been harder and harder to get people to driving evaluations unless they go to the DMV or MVA to do that. All right, sleep. So a lot of sleep issues. Again, almost everything you can think of with sleep. A lot of times we'll recommend sleep evaluations for sleep apnea, but we're doing other things too. Melatonin tends to be the first thing that we recommend, usually starting with 3 or 5 milligrams, and then every week going up to as much as 15 milligrams nightly. It can also help with the REM sleep behavioral issue. If that doesn't work, clonazepam or Klonopin, and then we would look into other sleep options. That's Dr. Catter, our sleep medicine specialist, who's good at managing these. We manage it as well, but if you need sleep studies, someone like her is who you would see. Now, some people can have pain with their disease. Usually this involves more neuropathy, so numbness and tingling in your hands and feet. Sometimes people have dystonia. These are kind of abnormal muscle contractions. Like a lot of people have curling of the toes as far as their dystonia goes. Some people have other muscle spasms that can cause them pain. Many times we'll talk about using duloxetine, otherwise known as Cymbalta, gabapentin or Neurontin, pregabalin or Lyrica as ways to treat this, or go to pain management. A lot of times, especially if it's dystonia, we'll do Botox injections, and that can help with pain as well, especially for abnormal muscle contractions and spasms. So what about fatigue? This is my slide on fatigue. So fatigue is a very common issue with Parkinson's. Almost everyone has it. The reason why it's kind of like this is because the answer, actually, to be honest, the answer is everything you just heard, right? So when we talk about fatigue, it's really something that we think is a little bit of everything added into one. A lot of times you'll talk to someone, they have Parkinson's, and you say, "You look great. You look great with your Parkinson's. You're doing so well." And they're like, "Yeah, I don't know. I just don't feel like myself. I just don't feel well. It's hard to describe. I'm just very tired." Whatever. It's because of all these other things that you can't see that they're dealing with, right? Even it's a little bit of constipation, a little bit of sleep issues, a little bit of pain, a little bit of anxiety. All of that added in adds to fatigue. And so when we hear this, we say, okay, what else is going on? Everything that I just talked about, what else is going on to really, address it? I just mentioned this here real quick. Sometimes we can use medical marijuana for painful muscle spasms, anxiety, insomnia. So just as another way to treat some of these non-motor symptoms. But a lot of times it's not a miracle cure, and so it's not an exact science either, and it's very hard to manage. We don't have recommendations on how to take it, how much to take it, how often to take it. So it's very frustrating for patients who have to just kind of guess at it, or ask the person, which I usually tell them to do, ask the person behind the desk, "Hey, these are my symptoms. What else do people with these symptoms take?" And then we don't have a lot of long-term data for medical marijuana in the setting of Parkinson's. It may increase the risk of dementia. So, just take it with a grain of salt. I mean, I do recommend it for a lot of my patients, but it's not for everyone. And nutrition and supplements, just a quick word about this. There's no diet or supplements for Parkinson's. I'm usually open if you read about something, sure. Most of the supplements won't hurt you and they could help you in different ways, but since nothing has been really well documented to help Parkinson's, there's nothing we can actively say. The Mediterranean diet is the only diet that can be helpful for brain health and to ward off dementia, and this has been consistently um, demonstrated. And then lastly, the protein issue for people who are on carbidopa levodopa, any food can get in the way of absorbing carbidopa levodopa, but especially protein. A lot of times in the beginning, and even throughout your disease, we don't tend to worry about this as much. When this starts to happen, people know it, right? They start taking their levodopa with meals, and they're like, "Wow, I barely felt the effects." Okay, now we know that the food is going to inhibit the absorption for you, so we have to address that. And that's it. I know it was a lot, but it was recorded, so you can go back and watch it 50 times. I don't recommend it, but you can do it.
And then they
Thanks,
can
Judy.
sort of cut in and cut out too.
Right,
You don't have
exactly.
to watch the whole thing all at once.
That's right.
Well, we've got a lot of questions.
Sure.
The first one is, do muscle relaxers, specifically BACLOFEN, I think that's
Baclofen.
right. Okay. Does that help with sleep disturbances? And does it interfere with maintaining muscle mass?
So it does not interfere with sleep disturbances, and it doesn't really harm muscle mass. There's a lot of just I would just say we don't tend to use muscle relaxers as much for other reasons, and so far as it can make you sleepy during the day or drowsy. Sometimes it can impact your cognition a little bit, and so it's just something that we use more rarely. We don't really have a strong indication for it. People usually with like back spasms or a lot of back pain are on them, and if they're helpful without any side effects, sure, they could be good medicines.
What are the most frequent non-motor symptoms of PD?
I would say the most frequent would be constipation for sure, and followed by probably sleep issues and or like the psychiatric issues like depression, anxiety.
Could itchy skin be a result of Parkinson's?
Yeah, so indirectly, itchy skin can be involved in. So if you, because I mentioned before that your changes in your sweating can change, right? And so you can actually develop more dry skin issues. And so indirectly, because of that, your skin can be more itchy. But what I will say is skin, yeah, it tends to be one of those things that we just say, "Well, go see a dermatologist about." And really, to be honest, you should have a dermatologist anyway because Parkinson's increases your risk of melanoma. So you should be following with a dermatologist yearly anyway.
Are the eyes affected by Parkinson's other than double vision, such eye problems as blurry vision and watering and redness?
Yes, so all of those things, especially the blurry vision, or the vision changes we're learning more about over time. The dry eyes can be really, people with Parkinson's don't tend to blink as much, and so they can start tearing up and be more irritated because of dry eye issues. And again, we do as mood disorder specialists, we treat most of these things. But again, I hate to say it, but that's again something to address with your eye doctor for the most part.
How critical is it to take Parkinson's medication on time each day?
So that depends on where you're at with your disease. I will say that in the beginning, it's not too important insofar as long as you take it around the same times each day, just so that there's not too much of a variable difference when you talk to your doctor as far as how you feel with your medicines throughout the day. Later in the disease, it's almost like you have to be a monk with your meds. I mean, you have to take them at the exact times because your body will tell you. And to be honest, it shouldn't tell you. You need to take the meds before your even body feels like the dopamine levels are dropping because that's what all of our brains are doing normally or should be doing normally is it's releasing constant dopamine at high levels um, for your brain and your body to use. And unfortunately, with the oral meds and when your disease progresses, you kind of go on this roller coaster ride, and that becomes a problem. So you really want to take them, especially later in the disease, very close. at the same time. Now, I will say it's more important to take them at the same intervals, meaning it's not the end of the day if one day you wake up at 8 o'clock and you start your meds at 8, and the next day you wake up at 9 and start your meds at 9. As long as they're at the equal interval that you arrange with your doctor, whether that's every 4 hours, every 5 hours, every 6 hours, every 3 hours, whatever. It's more about the interval than it is like, oh my God, I missed 8 o'clock because I was still sleeping. It's more about just when you start your day.
Okay, can diet be used to prevent dementia?
So, my last slide kind of alludes to that a little bit in the sense that,
Mhm.
the Mediterranean diet is the only one that's been proven to be helpful for that. But besides that, there's no other kind of good diet for data.
Okay, is there a known formula that's helpful for preventing or putting an end to either constipation or gastroparesis?
Kind of everything that I covered today as far as that goes. Gastroparesis would be the slowing of the stomach. Again, smaller, more frequent meals are going to be helpful for that. And then really working on the constipation because if your bottom of the GI system is slow, the top is going to be slow too. So because it's so much easier to treat the bottom part than it is about speeding up your stomach, if you treat the bottom part, everything starts flowing better and faster. Your stomach will flow better and faster too.
So I think you might have addressed this, but I'm just gonna say it anyway. Why does medication, carbidopa, levodopa, make me drool so much and lead to speech impediment affecting my cognitive processes of making a sentence?
So usually levodopa does not increase drooling. That's probably more coincidental than it is from the medicine. Um, because again, if anything, well, I would say probably the only way that that might be true is it is true that if you are maybe over medicated with the levodopa, a lot of people, from the name, get kind of doped up with it and get really kind of drowsy and out of it and really sleepy. And then they don't control their saliva as well. So it may come out and that be a problem. So that would probably be the only way it would be related to levodopa.
Okay, this is a long one.
Okay.
I was diagnosed with Parkinson's in 2015. I was a patient of the movement disorder physician that diagnosed me until November of 2023. I first saw him in Columbia, Maryland, and my final appointment was with him at his current office in Baltimore at the Brain Spine Institute at Sinai. Unfortunately, we had to switch to a movement disorder physician closer to home. I am no longer driving, and we have a 1.5 hour drive from Waynesboro, Pennsylvania to Baltimore. While the drive time appears reasonable, the traffic volume and intensity is nerve-wracking to say the least. No matter what time we would schedule an appointment, Maryland 140 in and out of Westminster was just nuts. I now see a neurologist in Frederick, Maryland. It's a 45-minute drive and the traffic pressure is less intense. My question involves staging of Parkinson's. Of the following, what do you use or prefer? Do you combine results of each, or do you measure staging strictly by one scale method? The Hone and Yar scale, can't read my own writing here, the Unified Parkinson's Disease Rating Scale, or the UPDRS-MDS? And are these two one and the same? I asked my original diagnosing physician where I placed on either the H and Y scale or the UPDRS scale, and he explained that he didn't feel that either scale was a perfect fit for all patients. He said he preferred to view each patient as an individual. Some categories could indicate a stage 2 and some a stage 3. He never rated or staged me. As we move forward at the end of each appointment, I would ask if he noticed any positive or negative changes and a summation of how am I doing. It seemed to work for us. What's your opinion? Told you
Yeah.
it was
So,
wrong.
yeah. Right. First of all, yeah. I mean, you definitely don't want to have to drive that far, although it's hard to get. Movement disorder specialist is always in your neighborhood. There is a good one in Frederick, though, Dr. Laura Brosby. So if you live in the Frederick area, she's very good. I would say that as far as staging goes, So the Hoehn-Yahr staging is very archaic at this point. It's used a lot in research still, but clinically it's not very helpful. It's a 5-stage system. It's really the only official quote unquote staging system for Parkinson's. I will say it's not very helpful clinically because you can go from stage 1 to stage 2 like that, and then stay in stage 2 for like 2 decades, right? So it's not, it doesn't, like if I told you that, I don't know how much information you get from that really, to be honest with you, besides going down a rabbit hole of, oh God, I was just stage 1 and now I'm stage 2. What does that mean? What is my prognosis? How am I progressing? It doesn't answer any of those questions. And so I don't even like to talk about that. I will answer it. Like if patients ask me, I really want to know, fine, you're in this stage, right? But then I always, caveat to what I just mentioned. Uh, the UPDRS motor score is something that I do often mention it to patients because it is essentially our exam that the movement disorder doctor does in a number form, right? So we are able to somewhat objectively measure how severe your different physical signs on exam are. Now, having said that, even that is far from perfect because I'm just examining you in a snapshot of your day, right? Now, I always record when you took your medicines last and when I'm examining you because guess what? If you scored way better last time and way worse this time, and I look back and I'm like, oh, well, last time I saw you on your meds and this time you forgot to take your morning meds, that's clearly the difference, right? So and then who knows what else is going on? If I'm examining you and you're in the middle of I don't know, going through some kind of like joint procedure and you're in so much pain and the pain's going to make your Parkinson's worse, at least at that point when you're going through all this kind of issues, then that's just inflated numbers from that visit, right? So it's really not a perfect system. Now, if everything is equal, right? I'm saying the same time of day, everything's fine, nothing's new, then yeah, a lot of times they'll be like, hey, you're doing so much better. And look, last time you weren't exercising, this time you are, and you scored 10 points better. Look at that. Look how much you can do with just exercise. So I will use it to make a point a lot of times, but so many other times it's just hard to say, like, what does that number mean in a vacuum versus what does it mean in this context, right? So, and what do how else do I say it? Yeah, I mean, I take the individual approach. I just say, look, you're mild, you're moderate, you're advanced, you're advancing, you're late stage, but what is that progression? What does that prognosis look like more than just saying a stage? Because again, that I don't know. I know everyone like hyper focuses on that, but until you know what that means in context, which by the way, even for more of a objective and subjective, we don't have more information to tell you, right? You can't look up right now. I mean, you probably could, but it's not any credible website to say stage 2 equals you have 5 years left to live, right? You can't find that anywhere. You can't find, what it means for you because it's such a spectrum of a disease. So, I hate the kind of just the generic answer of everyone's different. We take people uniquely, right? But at this point, because everyone's so different, in many ways with this disease, it's unfortunately the best answer for right now.
Okay, does anybody, that's all the questions that were submitted early. So does anybody have anything they want to say in the chat? No? Okay, I'm going to make a plea once again that everybody please fill out the evaluation forms that you're going to get. It is important. The physicians like to get know what the evaluations are. The funder likes to know what the evaluations are. So once again, I'm asking you to please do that. And I think that's it until the next time. So thank you,
Thank you for
everybody,
having me.
for tuning in. Thank you.
Have a great night.
You
Bye.
too. Night.